In this lecture, we will discuss left circumflex coronary artery occlusion, including the regions of the heart potentially affected and their corresponding EKG features. The right coronary artery is responsible for giving off rise to this posterior descending artery, okay, or we call the PDA in about 90% of individuals. This is what we call the right dominant coronary circulation. Therefore, in most cases, the left circumflex coronary artery will only supply the basal and mid parts of the posterolateral wall. This region of the heart is difficult to truly capture with the standard 12-lead EKG system. Now, in the other 10% of individuals that have a left dominant system, that is the PDA arising from the left circumflex coronary artery, the left circumflex coronary artery will also supply the inferior wall. And in about 10% of all individuals, the left circumflex coronary artery will also supply the AV node. Okay? So again, just to review our anatomy, here's our aorta, okay? We have our right coronary artery. Notice it comes around the right side of the heart and then supplies or gives rise to our PDA. We call that the right dominant system, okay? Then, in some patients, we can have what we call the left dominant system. Instead of the PDA coming off the right coronary artery, instead it comes off the left circumflex. So again, our left circumflex artery, here's your left main coronary artery coming off our aorta. It gives rise to the LAD as well as the left circumflex. And in the left dominant system, the left circumflex will come around the back and give rise to our PDA that will supply the inferior portion of that left ventricle, as well as sometimes give rise to supplying this AV node. Okay, so again, left circumflex, basal and mid parts of the posterolateral left ventricle, this region over here. Okay, as well as sometimes the inferior wall in about 10% of patients if they have that left dominant system. Okay, and also sometimes giving and supplying that AV node as well. Okay, so let's look at what happens if we have an occlusion of the left circumflex artery. So if the left circumflex artery only supplies the posterolateral wall in most individuals, occlusion will result in posterolateral MI. This is also referred to as a posterior or infrabasal MI. On the EKG, we can see similar changes to a posterior MI due to occlusion of the right coronary artery. We will see ST elevation in the posterior leads, V7, V8, and V9, along with reciprocal ST depression in leads V1 through V3, and sometimes even V4. These leads with reciprocal changes will also have these tall R waves and positive T waves. Okay, so again, let's just erase here. So we're affecting now, we're talking about these patients with the right dominant system. Okay, so the posterolateral wall is affected. Okay, so we have this back region affected, and because of that, we have V7 through V9, our posterior leads, that will show ST elevation. So again, those are not on our standard 12-lead EKGs, okay? And then we'll see reciprocal changes in V1 through V3. So V1 through V3, we are going to see our reciprocal changes, ST depression. Here's V1, V2, V3, and sometimes also including V4 as well, okay? And because of this, because it's affecting the posteral portion of the heart, we're going to see reciprocal changes. So remember, we see pathological Q waves as well as T wave inversions back here with the ST elevation in the posterior leads. And we'll see reciprocal tall R waves, which are pretty much the opposite of the pathological Q waves. And instead of having inverted T waves in those posterior leads, as we see, we'll actually have positive or upright T waves in leads V1 through V4. Okay, so they're pretty much reciprocal changes to the posterior lead changes that we see. Okay, so hopefully that's making sense. That's a posterolateral MI. So what if we have a left dominant system in which the left circumflex artery gives rise to the PDA? Now, occlusion of the left circumflex artery will now also involve the inferior wall. Therefore, an infraposterior MI will occur. In this case, we would see the same changes as above with the posterolateral involvement, along with ST elevation in the inferior leads, 2, 3, and AVF, and sometimes leads 1 and AVL, but rarely leads V5 and V6. Okay. So let's just erase this here. So now we're saying that we have a left dominant patient, okay, in which we don't have the PDA coming off the RCA, okay, so it's not on this side, but it's coming instead from this left circumflex that's coming around and supplying this region, okay? So imagine that we have the left circumflex coming around, and then we have this occlusion here, okay? This occlusion here is now affecting the inferior portion of the wall, okay, as well as that back portion, that posterior portion of the left ventricle. So we have a posterolateral MI as well as this inferior involvement, okay, which we call an infraposterior MI, okay. So again, we're going to see ST elevation in the posterior leads, V7 through V9, because the posterior wall is affected. We'll also see now that the inferior wall is infected, so our inferior leads 2, 3, and AVF will show ST elevation. Okay, sometimes you can see ST elevation in leads 1 in AVL, okay, so these ones here, and sometimes V5 through V6, but rarely, okay. Now you'll also see those reciprocal changes in those anterior precordial leads, V1 through V4, tend again to show those reciprocal ST depression, and they'll also show those tall R waves and the positive T waves, which are those reciprocal changes to what we see in the posterior leads. Okay, so again, hopefully that's making sense. And again, the inferior infarcts, the inferior involvements 2, 3, and AVF, we'll see ST elevation in these leads. Okay, 1 in AVL, you may also see involved 2. In this case, because of that lateral portion, that posterolateral wall over here involved. Okay, but rarely you'll see V5 and V6 involved. And again, reciprocal changes here in the front, okay, the anterior portion of the wall, because it's not affected, where you'll see reciprocal ST depression and those tall R waves in the positive T waves in those leads. Hopefully this is starting to come together and you're starting to make out the different anatomy and how this is all relating. So let's quickly review what we discussed before we end. So again, the left circumflex coronary artery supplies the basal and mid parts of the posterolateral left ventricle, okay, as well as if you have a left dominant patient, in which case you'll have the inferior left ventricle also involved or supplied. The AV node may also be supplied in such cases. Now, if you have a left circumflex occlusion in a normal right dominant patient, you'll have posterolateral involvement. Okay, so that posterolateral wall will be affected. In such cases, you'll see ST elevation in V7 through V9, reciprocal changes in ST depression in V1 through V4, the tall R waves, the positive T waves in V1 through V4, okay, those anterior leads. In a left dominant patient, as above, you know, we're going to see the same changes because we have posterolateral involvement, but now we're also adding the inferior portion of the wall, okay. So we'll see ST elevation in V7 through V9, inferior region now involved, okay. So we have now the inferior portion of the left ventricle that's affected, and because of that we see inferior ST elevation in those leads. We can also have leads 1 in AVL and sometimes V5 and V6 that also show ST elevation. Again, reciprocal changes in V1 through V4, the ST depression, the tall R waves, and the upright positive T waves. Well, that's the end of this lecture. We discussed left circumflex coronary artery occlusion, including the regions of the heart potentially affected and their corresponding EKG features. I hope you learned something.